A very good evening to all of you. I'd like to welcome you all for the second academic activity of Neuromuscular SIG. And today we'll be having 4 short case presentations on floppy infant. I'd like to request our President, Dr. Shefali Gulati ma'am, to introduce the experts.
Yeah, thanks. I think it's nice as a second session for the neuromuscular disorder. We'll having cases from across India with our new budding pediatric neurologists being mentored by their faculty. I want to thank Dr. Lokesh Lingappa, President-elect, and Dr. Rajesh Madhu. Thank you so much for joining from London. And I know that you are available only for 45 minutes. So we will request you to make more comments during that time. And the session will be moderated by Priyanka. Priyanka, can you start off? Yeah.
Yes.
Thank you. You can, and once again, I forgot, with the cases will be discussed, but then the most important part is Dr. Rachna Dubey will be presenting a flow approach for the floppy children. So we have 4 cases with their 4 moderators with 2 experts, Dr. Lokesh Lingappa, President-elect AOCN, and Dr. Rajesh, was so experienced in neuromuscle and among other things. And then Dr. Rachna Dubey will give a flow approach, an SOP kind of thing of how do you approach floppy children. And thanks you all for joining. And over to you, Priyanka. And it is really very overwhelming to have my own students now who become so big and being there, but make me feel very elderly now. Chalo. Priyanka, over to you.
Thank you, ma'am.
Priyanka, one second. And I also thank all the SIG members who have joined, and I'm really grateful for the same. Yeah, please, Priyanka, all over.
Thank you, ma'am. So I extend my warm welcome to all to the today's session on floppy infant, interesting cases and approach. So in today's session, as ma'am mentioned, we have 4 interesting cases lined up from 4 different institutes. So without taking much time, we would begin with the first case. So we have Dr. Aradhana Rohil, who is a DM resident at AIIMS, New Delhi. And she would be presenting an interesting case of an infant with motor delay under mentorship of Dr. Prashant Johri sir, who is additional professor in Department of Pediatrics at AIIMS, New Delhi. So over to Dr. Aradhana.
Good evening, everyone. Ma'am, I'm not able to share my screen.
Asmita,
now we can share.
No.
Hello.
Yeah.
Can
Yeah.
you check?
Yeah. Is my screen visible?
Yes, ma'am.
Yes.
Screen visible.
Good evening, everyone. I'm Dr. Aradhana. I'll be presenting a case from AIIMS, New Delhi. Our case is a 9-month-old boy who presented with complaints of delayed attainment of milestones and floppiness. I'll be starting from the birth history. The child was first born to a 3rd-degree non-consanguineous marriage with an uneventful antenatal period. He was delivered at term by LSCS in view of prolonged labor. The birth weight was 2.3 kg and the child cried immediately after birth. Subsequently, on day 4 of life, the child was admitted in NICU in view of respiratory distress. At this time, the child had a prolonged NICU stay of 2 months for LONS, pneumonia and anemia, for which the child was treated at an outside hospital. And there, the child had difficulty in extubation due to thick secretions and requirement of suctioning devices. Based on these findings, the child was suspected to have cystic fibrosis versus a primary ciliary dyskinesia. And for this was evaluated by the treating team with an exome sequencing. However, the exome sequencing did not reveal any significant information. Subsequently, the child was discharged at 2 months of life. At 2 months of life, after discharge, the parents noticed the child to have a foot deformity in bilateral feet in the form of inward deviation of bilateral feet, for which the child was under orthopedic follow-up and was advised casting. The parents also noticed that the child was very floppy, and the mother complained that while handling the child during dressing and all, the mother used to feel that the child was very loose. The parents also noticed the child to have delayed attainment of milestones. Like at 3 months, they noticed the child had no neck control. However, social smile was present. Subsequently, at 6 months, they noticed the child to develop partial neck control with palmar grasp. However, the child was not able to reach out for objects. Cooing had started developing, and the child was able to recognize parents. Currently, at 9 months of age, the child has a complete neck control, is able to roll over from supine to lateral position, can sit with support, has palmar grasp, but cannot reach out for objects or transfer objects, and stranger anxiety has not developed. This correlates with a rough motor age of around 3 to 4 months and a mental age around 6 months. The child also had excessive drooling. This is the image of the child from the neonatal period when he was admitted. The child is lying in the cot with a frog-leg posture, indicating generalized hypotonia. However, there was no history of polyhydramnios or reduced fetal movements during antenatal period, no history of any vision or hearing deficit, no history of abnormal eye movements or eye position or tosses, no history of facial deviation while crying or poor sucking, no history of nasal twang while crying or nasal regurgitation of feeds, no history of variability in the level of activity or weakness throughout the day. There were also no history suggestive of any sensory involvement, no history of seizures, altered sensorium, or other abnormal body movements, and no history of any abnormal body odor, rash, skin, or hair changes. There was also no history suggestive of any stiffness in mother or any motor problems in mother. Coming on to the examination. On examination, the child was noticed to have subtle facial dysmorphism in the form of flat nasal bridge and retrognathia. Also, there was a high arched palate. There were no neurocutaneous markers. Spine was normal and bilateral lower limbs were casted. Anthropometry was within normal limits. Coming to the CNS examination, the child was alert, awake, and playful. Cranial nerve examination was within normal limits. There were no tongue fasciculations. As we can see in the video, the child can be seen to have a poor head control. Also, there are some anti-gravity movements in both upper and lower limb distally, whereas the proximal anti-gravity movements are not much significant. So, to summarize a motor examination, the bulk was normal. There was proximal more than distal muscle weakness. There was generalized hypotonia, both axial and appendicular, with a head lag. Hyporeflexia was there, and bilateral ankle contractures were also noted. Further, sensory examination was within normal limits. No cerebellar or extrapyramidal signs were seen. Fundus examination was also normal. And examination of mother was also done. There was no evidence of grip myotonia. Other systemic examination was within normal limits. There was no organomegaly. So to summarize, we have a 9-month-old boy who is first born to a third-degree non-consanguineous marriage with motor predominant global developmental delay with subtle dysmorphism, with generalized hypotonia, proximal more than distal weakness with hyporeflexia and bilateral ankle contractures and foot deformity with no fasciculations, normal vision and hearing, normal extraocular movements, no organomegaly, and normal examination in the mother. So with this information, we kept the possibility of congenital myopathy in view of the infant being floppy with weakness and since the child was gaining milestones. However, the child also had subtle facial dysmorphism and there was mild delay in the language as well as socio-cognitive domains. So we also considered the possibility of congenital muscular dystrophy. Other possibilities considered were spinal muscular atrophy and congenital myasthenia syndrome in view of the floppy infant with the respiratory involvement. However, the child was gaining milestones and there were no fasciculations and no diurnal variations in the symptoms. So the child was investigated and we found a very high CPK value of 1862 and 2000 on two separate occasions. This made the possibility of a dystrophic process more likely. So we considered the possibility of congenital muscular dystrophy upfront. We went ahead with the MRI brain. The MRI brain showed bilateral parieto-occipital T2 flare hyperintensity, and the cerebellum and the brainstem were within normal limits. So with this, we suspected the possibility of a Merosin negative congenital muscular dystrophy, for which we went ahead with exome sequencing, which demonstrated a pathogenic variation in LAMA2 gene. So our final diagnosis is that of a Merosin negative congenital muscular dystrophy with pathogenic variation in LAMA2. There are subtle pointers for clinically suspecting CMD. They include in a child with in a floppy infant. They include paralytic weakness with dysmorphism and CNS and malformation, as in our case. Then paralytic weakness with global developmental delay with UMN signs, and also those who have early contractures and congenital hip dislocations. However, there are points like if there is presence of prominent facial weakness, early ophthalmoplegia, respiratory failure at birth, or congenital cardiomyopathy, then there are pointers against CMD, and we should think of other alternative diagnoses. The various clinical subtypes of CMD include collagenopathies, myrosinopathies, dystroglycanopathies, and SEPN1 and LMNA related CMDs. There are a few subtle pointers for each of these. Collagen-related CMDs present more with proximal contractures and distal laxity and a soft velvety skin of palms and soles. LMNA-related CMD, they mostly present with early contractures and scapuloperoneal weakness and cardiac involvement. Myrosin deficient CMD, they mostly present with a mixture of hypotonia and UMN signs. 30% can present with seizures. They also have early contractures, which are more distal predominant. And MRI can have non-specific white matter signal changes, as seen in our case. On the other hand, dystroglycanopathy-related CMDs, they have they are a type of syndromic CMD because they have other manifestations like facial dysmorphism, ophthalmologic abnormalities, and MRI brain findings, which include cortical migration defects, especially listen-cephaly, as well as infratentorial defects like pontocerebellar hypoplasia, cerebellar cyst, as well as occipital encephalocele, etc. And SEPN1 related CMDs, they mainly present with the initial axial hypotonia followed by later rigid spine. Thank you.
Thank you, Dr. Aradhana, for the interesting case. Now I would request Prashant sir to mention a few take-home messages from this case and some learning lessons.
Thank you, Priyanka. Thank you, Aradhana, for presenting in a very lucid format. So we actually are going to have a lecture on approach to this floppy infant. So I'll not take much time. Just from this case, the learning point was that if you have paralytic weakness with some form of non-motor delay or there is subtle dysmorphism, these should make you think of a muscular dystrophy rather than SMA, which is again a top diagnosis in a floppy infant. So this is what we followed here, and the weakness started from the neonatal age itself. So had it been an SMA, it would be SMA type 1. But then the gain in milestone moved us away from it, and then there was no fasciculations as well. The CPK's lead was clear that the possibility is of a dystrophic process, and that is why we proceeded with this. Now, once you think that you are dealing with a CMD, then MRI actually helps you to actually delineate between the various subtypes. So at this age, generally we have dystroglycanopathies or a myrosin negative coming to us more commonly than collagenopathies, which present slightly later in life. So here again, as Aradhana has pointed out, that if you have primarily white matter changes, primarily in the parieto-occipital with sparing of corpus callosum internal capsule, you think of a myrosin negative CMD. If you have with or without white matter changes, there's a lot of pontine hypoplasia and cerebellar degeneration or cerebral cyst with or without any malformation of cortical development like cobblestone leukoencephaly, then that is a pointer towards your dystroglycanopathy. And when you club that MRI with clinical features, with ophthalmological findings, then you can further delineate dystroglycanopathies into the 3 subtypes which are there. So that is what I would want to add here. Thank you.
Thank you, sir.
Dr. Rajesh Madhu, Priyanka, we'll ask Dr. Rajesh Madhu because he's there and he's really, thank you that you joined from Liverpool.
Yeah, thanks very much. So we've got a number of these children with lemma too. Yeah, I think the phenotype, early phenotype is exactly as you discussed here. Although we see white matter changes, most of them have fairly normal intellect. They go to kind of mainstream normal school. Most of them fail to attain walking in our experience, but they can shuffle along the floor, fairly good upper limb strength. And yeah, we have to monitor for scoliosis. Increasingly, there's reports of cardiac involvement in these children. So we now tend to monitor their cardiac ECG echo regularly. Yeah, I think there's nothing else here. Thank you.
Dr. Lokesh Lingappa.
I think most of the points have been covered. So we'll go on to the next case. Thank you.
I think one thing I would like to tell, there's something has come up in the last few years for congenital myopathies and CMDs, when you talk about genetics, so you can have the same genes causing multiple kind of things which are totally different. So one has to keep that in mind. And I think Dr. Rachna Dubey would be talking about it. So that has changed the landscape of way we look at it. And also we have to understand that in many of the, especially congenital myopathies, we are having this new muscle MRI and the involvement of particular muscle groups, which are giving us some leads, when otherwise, obviously, genetics is taking over everywhere. Want to say something about that, Dr. Rajesh?
Yeah. So I think in our experience, muscle MRI has not been very useful in the early stages. And I think it does evolve over time. So just as an example, collagen 6 has got a typical muscle MRI pattern, but we don't see that in younger children. So it is there as you get older. And
how about ultrasound? Because we've been trying to we've done a couple of studies trying to explore ultrasound of the muscle in the floppy children. We've just, so
yeah,
what do you think about that?
I must say, we don't do it ultrasound in a floppy infant situation, because I think the way things have changed is it's kind of genetics have taken over as a primary first line diagnostic test.
Yes.
And we do rapid whole genome sequencing and we do get the results within about 10 days or so. So it's that's kind of moved everything out of
what you were saying then, Dr. Rajesh, we've had some series of genomics related webinars, what the experts say, and what Vinod Skaria said that in a couple of years everybody will be having a personalized genome, and the whole genome sequencing is going to be replacing it, just the financial thing which is coming up. So we were doing that. Absolutely right. But you give advice to our a bit resource constrained situation.
So difficult, yeah, exactly. So I think clinically you can. I think there's a very the fair degree of muscle weakness, distal contractures, high CK with white matter changes on MRI. I think that makes it a congenital muscular dystrophy lemma 2 very likely. But yeah, I think as you said, the phenotype can be quite variable, and I think people are moving away from describing as myopathy, muscular dystrophy, etc., to a gene-related problem, and then there is a spectrum of presentation. But hopefully, as we do genetics more and more, we might move away from this kind of classical descriptions.
Priyanka, ask Krishan.
Yes, sir, please.
I fully agree with what Dr. Rajesh said. Just one thing, maybe as a clinician, sometimes if you do an IHC and you see that there's a partial deficiency of medicine compared to a complete deficient medicine, there's no uptake of medicine, then maybe it sometimes predicts the future course. So then you will definitely have a non-ambulant baby when you have a medicine deficient one. And when there's a partial deficiency, then there is some likelihood, there is some way by which you can actually prognosticate them. So I don't know how much the West is actually using this tool, but sometimes it helps. Thank you.
Yeah, we do histochemistry as well.
Thank you, sir. Ma'am, shall we move on to the next case? So moving on to the next case, which is from AIIMS Jodhpur. We have with us pediatric neurology fellow from AIIMS Jodhpur, Dr. Ashna Kumar. who would be presenting the diagnostic journey in a neonate with a treatable cause of floppiness. And her mentor is Dr. Lokesh Saini, who is assistant professor in pediatrics at AIIMS Jodhpur. Over to Dr. Rachna Kumar.
Good evening, ma'am. I hope I'm audible.
Good evening.
Yeah. Please share your slides.
Yes, ma'am. Just a minute. Ma'am, is my screen visible?
No.
Not yet.
I hope it's visible, ma'am.
Yes, we can. Yes, we can see your slides.
Click on slideshow mode. Yeah.
Yes, ma'am. So, good evening, everyone. I'll be presenting another interesting case of a floppy infant, this 24-day-old floppy infant with a treatable diagnosis. This 24-day-old neonate presented to our emergency with the chief complaints of reduced limb movements that were noticed by parents since last 2 weeks and weak cry that was noticed since past 5 days. The antenatal history as such was uneventful, except that mother had moderate anemia during the antenatal period, for which she received IV supplementation. And this child was first born to a non-consanguineous married couple, 37-weeker, born by LSCS in view of obstructed labor with some fetal distress, with a birth weight of 3.3 kg. However, the immediate perinatal period was uneventful, and the child did not require any resuscitation. At around 13 days of life, child developed fever that was mild in grade and did not hamper the routine activities of having milk or did not cause letharginess. But subsequently, the child developed reduced generalized limb movement that were noticed by the parents, associated with decreased spontaneous activity and a weak cry. There were no associated history of any prelactal feeds, decreased feeding prior to the onset of symptoms, no history of any poor suck or abnormal body movements, no history of any similar complaints of weakness in mother, no any significant family history in the form of weakness, ptosis, or exercise intolerance. On examination, anthropometry-wise, the child had a normal anthropometric measurements. Vitals were stable at admission. There was no dysmorphism. There was slight facial asymmetry that was noticed in the form of low motor neuron facial palsy. There were no neurocutaneous markers, no ptosis, no edema, no muscular atrophy or hypertrophy that was noticed. The focus CNS examination revealed that the higher mental functions child was a bit irritable, had a weak cry, however had spontaneous eye opening that was present. On cranial nerve examinations, there was right low motor neuron facial palsy, a weak cry, and other cranial nerves within normal limits. Motor examination revealed that the child had generalized axial and appendicular hypotonia, that a frog posture was noticed, and power, there was a flicker of contraction that was noticed, and this power was low both in the proximal as well as the distal muscles. The respiratory efforts were shallow, and reflexes were not elicitable at all. There were no tremors or fasciculation, however. So after a complete history and examination, we had a 24-day-old neonate, which was first born to a non-consanguineous marriage with a history of anemia in mother during the antenatal period, with normal immediate perinatal period, with a history of viral prodrome in the form of fever and coryza, followed by floppiness that was noticed by the parents since second week of life. On examination, significantly, there was hypotonia with areflexia, with weak respiratory efforts and weak cry, and a low motor neuron facial palsy. This is the video of the child when the child was examined in the nursery. The child was given respiratory support in view of his poor and shallow respiratory efforts, and the child had generalized hypotonia. We see that when we are examining for the tone, there is complete floppiness to all joints. In the upper limb, we can see that the joints are floppy. The child is having a pit frog posture. Similar floppiness was noticed in the lower limbs also. We were able to move the child, move the limbs in all directions. There was extreme floppiness which was present, and associated, there was areflexia. So coming on to the differential diagnosis, we thought of the common things first. So sepsis was a first differential, but this was sepsis probably associated with complications. The child had a preceding history of fever and coryza with hypotonia, weak suck and cry. However, there were no seizures, AF was at level, the areflexia was a bit against the diagnosis, and the child had a non-toxic look. Then we also thought of the neurometabolic disorders which can present like this, having a history of acute illness followed by floppiness and weak cry and hypotonia. However, there were no acidotic breathing. The child was born to a non-consanguineous couple. Then we also thought of some early neuromuscular disorders like congenital muscular dystrophy and SMA. But there were many points that did not favor these diagnoses. There was no muscular atrophy or hypertrophy. There were no contractures, no hyperlaxity of joint, and for SMA, there were no fasciculations which were present. Congenital myasthenia was also what we thought of, but yes, there was no ptosis, there was no diurnal variation, no apneic episodes that were noticed in the newborn. Then we thought of botulism, that is an acquired cause, but there were no history of any prelactal feeds. The child was exclusively breastfed, and we always wanted to rule out any treatable diagnosis that we could be missing in this child. So neonatal GBS was one of our diagnoses. We had hypotonia, areflexia, a preceding viral prodrome, associated respiratory weakness. However, the age group was very atypical and there was no history of weakness present in the mother. We went ahead with the investigations. The basic investigations were all within normal limits. CSF was normal. There was no raised proteins. There were just 2 WBCs. The thyroid function tests were within normal limits. So SMA was one of a possibility. Along with that, we sent the MLPA for SMN gene deletions, but we wanted to rule out the a treatable diagnosis. So we went ahead with the NCV while meanwhile awaiting further reports. So NCV revealed that there was increased latencies which was present in the motor conductions as well as the sensory nerve conductions, which wasn't recordable at all. So we thought of a demyelinating sort of neuropathy. We went ahead with the MRI. MRI routinely is not done in a case of GBS, but yes, we have been following this practice of doing an MRI in our center, and we've seen that we are able to pick up the diagnosis of GBS at a very early stage. We see that the caudal nerve root enhancements which was present in the sagittal section, axial section revealed the same, that the anterior nerve root enhancement was present along with the posterior. However, the anterior was more enhancing, and on the brain MRI there was enhancement of the third cranial nerve also. So our final diagnosis was neonatal GBS, taking into consideration all the history that the child initially was fine, and then at 2 weeks he started with the history of weakness and floppiness, and then a supported evidence and the investigation, NCV and MRI, that supported our diagnosis. We went ahead with the treatment. We gave IVIG at 2 grams per kg over 2 days, and we found that the child significantly improved. So neonatal GBS is a very rare diagnosis. There are just a few scanty case reports that we've been able to find out in literature. The GBS, the most common age group that we see is mostly after 3 years. But yes, neonatal cases have been reported. There is usually a preceding viral prodrome. Respiratory tract infection is more common, followed by GI infections. There have been case reports where the neonatal GBS has been reported in infants born to a healthy mother. And there are also case reports where they show that the mothers who are suffering from an autoinflammatory disorders have a predilection for their infants to suffer from GBS. And the epidemiological data, though, supports that the age group is very odd, but yes, neonatal GBS does exist and it is a treatable entity, so should be identified early. This is the video of this child. 3 weeks after treatment, we see that there are no focal deficits. The child is able to move the limbs very nicely. We don't find any power deficits. And this was 3 months after treatment. The child came to our follow-up and is having normal development and growing normally. So with this, I wanted to bring forward the key messages that an appropriate history and examination is always the clue to the correct diagnosis, and we should never miss the treatable differentials of a floppy infant. MRI imaging is coming up as a useful imaging modality for early diagnosis of GBS and to rule out other differentials. And we have been using this modality. In fact, we are doing a project at a center where we are trying to show that MRI can be done very early and can help us pick up cases very early in their progression, and we have been seeing that some cases who presented to us with very atypical presentations, also with just few pain, low limbs, that we might think of viral myositis and other differentials. And we did an MRI thinking the suspicion that the child had some weakness that was progressing, and we found out that there was caudal nerve root enhancement, and so we could reach to a differential of GBS, and we treating them accordingly. Thank you.
Thank you, Dr. Rachna, for the very interesting and unusual case. So I would request Dr. Lokesh Saini, your mentor, to give a few comments.
Good evening, everyone. So this case was a learning experience for me too. I have never seen an neonatal GBS before this, and a lot of learning by this case. We thought of this, we proved the diagnosis, we treated the child, and the outcome was very fantastic. So first thing was that, which made us very happy, and we wanted to share this with, we are even writing this. So there are some clues in this case, definitely. Clinical clues were there, LMN facial palsy. Then there was some normalcy period and then deterioration after a viral illness. But most important, the age is not with us, and experience. So, I've never seen it. So suspicion was doubtful. So that is why we went with MRI also, which we are doing routinely, as Ashna has mentioned, that we are also developing a scoring system for predicting ventilation in GBS based on MRI. So we are doing that. So it was a good learning experience for us. I can clear any doubts if anyone has. Thank you for giving us the opportunity.
Thank you, sir. Sir, what were the long-term outcomes in the published cases with neonatal and congenital GBS? If you would like to.
Very rare, 5-6 cases we have found out. So all have survived and all have improved. All have improved. So because they have normal development, because these are neuromuscular disorders. So development, definitely, if we treat early, no hypoxic insult occur to them, they will improve.
Very interesting.
Yeah, very interesting. Thank you so much, Lokesh. Priyanka, you can ask the experts.
Yes. So
I think, Priyanka, just a quick this one. I think it's the important point which was made in this case is doing an early post-contrast lumbosacral spine MRI. I think it is most of us pediatric neurologists are going to this because, as you know, the early nerve conduction are normal, even with a severe GBI in early on. So it's a way of confirming the diagnosis. I think most of us do practice this because neither the nerve conduction nor the CSF will give us information. So I think that's a very good case which has been picked up. So I think a thorough examination considering a wide range of differential, including the treatable pathologies, is important, as what the team has shown. So I think congratulations for the nice case. Thank you.
Thank you, sir. Dr. Rajesh?
No, I've got nothing to add. Very good case. Thank you.
And very interesting learning lesson. So,
yeah, Priyanka, 1 second before that, you please see the chat, and you please, even the previous case, you had one question pending. So can you please read the chats also simultaneously? So the first question is from the previous one, and the rest these. Can you please keep reading and asking the experts?
Yes, ma'am. Yes, ma'am. So the first question is, did you perform anti-ganglioside antibodies in your case with neonatal GBS? Not needed for diagnosis, but given the rarity of case, could have given more insights into the mechanism behind inflammation.
So our experience with this anti-ganglioside antibody is very poor. Like most of the time it is negative, even the classical GBS. So we don't do it routinely nowadays. So because very low yield, I am around 60 cases we have seen last 2 years of GBS, and we have not found any. And first 50 we have tested, but not a single one is positive. So we don't do it.
Okay. So the next question is from Dr. Kirti Kunja. We had a similar case of 2-month-old child. CSF analysis was normal. MRI showed cauda equina enhancement. We treated with IVIG. However, the child did not improve. Later, we sent SMN gene, which came positive. Oh, this is a comment. Dr. Partha Ray has asked, what was the protein in CSF normal?
Yes, yes, because it was done on day 1 of illness, day 1 or day 2 of illness. It was normal at that time.
And Dr. Harshuti Shah is asking, how do we differentiate it from septicemia complication, as there also we get improvement with IVIG?
Ma'am, the nerve conduction was favoring the GBS classical pattern in MRI, which we were seeing in other cases. Then the history and the improvement, brisk improvement after IVIG, and child was off NIV, non-invasive ventilation. Child was on non-invasive ventilation also. And there was no sepsis markers in the child. So they were tested too. So no sepsis markers, no procalcitonin was normal, CRP was normal, CBC was normal. So septic screen was also negative, as well as CSF. So we were not thinking of sepsis. But we have ruled out upfront.
And then we have a question from Dr. Malini. Could COVID present with GBS? So in
Yes,
older children, it's well known, but in like neonates, are there any reports?
Interestingly, this child, because it was unusual, so we have sent COVID antibodies, and it came very high. This child, we did not show it because everybody is positive nowadays. So that is why we have not done.
Lokesh, you should have still shown it, huh? You should have still shown it. It would
Yes,
have
so
even
COVID
raised some more curious. Yeah.
COVID antibodies are positive for this child.
Yeah, Dr. Malini thank you for joining so late. It's so late in Malaysia this right now. Yeah. Continue with Priyanka.
Ma'am, last question, neonatal GBS, which part affected, first sensory or motor? From Dr. Mehdi.
So clinically, it was weakness, which was proximal and distal both, and the neonate. As when the child came, was completely floppy. And in nerve conduction, what we got is sensory completely absent. So probably that is the finding in our case, but it is not the pattern for all GBS.
And all the reports are showing demyelinating, or some are showing axonal pattern also previously?
Axonal also. MRI will be positive for both. So
Priyanka, you have one question for Prashant also.
Yes, ma'am. Maybe I missed it. Ma'am, is it in chat? There is another question. Did you take neonatal values of NCS into consideration, as that was one of the diagnostic markers? Only the MRI and therapy response was used as diagnostic here.
No, yes. NCV also, we have repeated also, it has improved completely. We have repeated. And the clinical, most important is the clinical. The child has improved dramatically after IVIG, and the response to therapy was wonderful. And definitely we have done NCS after that, and it has improved after 3 months.
Ma'am, I could not find that question.
Yeah, the first question, which was from the first case pending, is LAMA2 mutation was missed in the whole exome of the newborn period. Please explain, Prashant. And then Renu has to say something, Priyanka. Ab dekho, hand raised hota hai na?
Thank you, ma'am. Thank you for that question. First, I'll say, Lokesh, that this case was
It's
actually
not my
very
question.
interesting.
Yeah.
Okay, ma'am. Whoever has asked, that is quite a relevant question. I'll come to that. But let me first congratulate
Once again,
Lokesh.
Uddhav has asked. Achha, sorry, yeah, you congratulate.
Okay, ma'am. So this is quite an interesting case. We have come down to almost a year, 6-month kids with GBS, but then this was an eye opener that we need to suspect them in a neonatal period as well. So at that age, it will be very difficult to say what was motor predominant or a sensory predominant course in a small neonates. It will be a difficult case, and we don't know how many cases. Once we have more and more information, then maybe a pattern can arise for what actually is in a neonate when GBS affects. And as far as this question that Dr. Uddhav has asked, so see, I have just one single answer for you, is that if you don't ask the right question, you will never get the right answer. So the question, all of these labs, they put it on an Illumina platform and they run the case. depending upon the phenotype that you talk about, they actually do a analysis of that part. So possibly when in the neonate period, the treating physicians kept a possibility of a primary ciliary dyskinesia. So they actually were looking on that. And probably that is why they never thought of looking at other pathogenic variations. That is one answer that I have. So the prudent thing here is that you need to ask the right question. You have to phenotype a kid well, then only the genotype helps. And rarely in these clinical settings, a retrophenotyping is actually required. So that is, if I hope that answers your question, Dr. Uddhav.
Thank you, sir. Dr. Renu, please.
Thank you, Dr. Priyanka. Wonderful case presentation by AIIMS Jodhpur team and Dr. Lokesh, very nicely worked up case. My question is how difficult or how easy it was to perform NCS in a 13-day-old baby because some of the sensory potentials may not be elicitable because of technical issues also. So I want to know what is the range of velocities which you got that you really thought of that is a demyelinating variant of
actually, in our case, we would have not done NCS because we are doing MRIs for fitting GBS in our center primarily. But we have done this in this child because of persistent doubts from neonatology team. They were not believing it is GBS because they have also not seen this entity before. So they were compelling us to do this NCS. We have done this. And we have checked the values at that time. Sensory was not elicitable at all the nerves. And this motor nerves all are having prolonged latencies as well as decrease, very, very decreased, in the range of 15 and 10 velocities were. So this is supporting our diagnosis.
Thank you.
So I think in view of time, we should move on to the next case.
Can I disappear? Is that okay?
Please.
Thank you.
Priyanka, please. He had to log out. Yeah.
Okay. So for the next case, we have a team from PGI Chandigarh. So I request Dr. Siddharth Khanna, who is a DM resident at PGI Chandigarh, to present the next case, which is another cause of infantile hypertonia under the guidance of Dr. Renu, who is a faculty at PGI Chandigarh and convener of Neuromuscular SIG. Dr. Siddharth.
Very good evening, ma'am. I might be sharing my screen.
Please.
Ma'am, is my screen visible?
Yes. Please go to the screen sharing mode. Slideshow mode.
Is it visible, ma'am?
Yes.
Yes, it is visible, Siddharth.
Okay. Very good evening. I'll be presenting the case from PGI under the guidance of Dr. Renu, ma'am. So we have a 3-day-old boy who's born at term, 39 plus 3 weeks, born of an emergency LSCS with low birth weight of 2.4 kg. The child did not cry immediately after birth and required resuscitation for 2 minutes. The child was immediately admitted in nursery after birth. And finally, a pediatric neurology opinion was sought on day of life 3 with the chief complaints of paucity of spontaneous movements of upper and lower limbs and floppiness of limbs. In antenatal history, the mother was taking antenatal care from some local hospital in her hometown. She was gravida 2. The previous pregnancy was 3 years ago. LSCS in view of non-progression of labor with birth weight of 2.7 kg, no signs of neonatal encephalopathy. According to the parents, the child is healthy and has achieved age-appropriate milestones. The mother was well supplemented and immunized with no exposure to radiation or cytotoxic drugs, no history of fever with rash, no history of polyhydramnios, no history of reduced fetal movements as compared to the previous pregnancy. Quickening was felt around 22 weeks. Antenatal scans were done 2 times. At 20 weeks, it showed prominent lateral ventricles and adequate liquor. And at 31 weeks, it showed bilateral ventriculomegaly and right renal pylectasis. The patient was referred to PGI in labor in view of late onset fetal growth restriction. In intrapartum, the child did not cry at birth, was small for gestational age, and required resuscitation for 2 minutes. The Apgar score was 4 and 7. The indication for referral was the late onset fetal growth restriction in view of increased uterine artery pulsatility index. The child had immediate distress after birth and was initially put on oxygen by nasal forms. On day 1 of life, he required oxygen. The child had reduced cry and was increased drowsiness and had difficulty initiating oral feeds and hence was put on OG feeds. There was paucity of movements and floppiness noted from day 1 of life. On day 2 of life, there was worsening of symptoms. The child had aspiration with apnea, requiring bag and tube ventilation. However, there was no bradycardia or cardiac arrest, and then was put on CPAP mode of oxygen. There is no history of seizures, no history of obvious limb, skull, or spine deformity, no history of inability to close eyes, no history of swelling over scalp, fever, or rashes, no history of abdominal distension. The child is born of a non-consanguineous marriage. He's second by birth order. There is a history of 3-year-old girl with global developmental delay and epilepsy. However, since I took the history from the relatives, as the mother was not available at the bedside in the nursery, so the details of this patient are not available with us. We have asked them to bring the child to the clinic for detailed assessment. On examination, the child was looking sick with reduced movements of upper and lower limbs, with shallow reduced movement of chest wall. The head size was 33 centimeters with over adding of sutures, AF 1.1 into 1.5 into 1.5 centimeters at level. There were no eye changes, no megalocornea, coloboma, corneal opacities. There was V-shaped upper lip, high arched palate, some pectus excavatum. There were no neurocutaneous markers. Cryptorchidism was present, and the child had right foot equinus deformity. The child was drowsy, had diminished arousal with diminished spontaneous movements of both upper limbs and lower limbs, with lower limb affected more than upper limb. On cranial examination, the pupils were equal, 2 millimeters. A red reflex was present. There was no restriction of extraocular movements. However, rooting and sucking reflex could not be elicited. The child had facial weakness in form of tented V-shaped upper lip and kept his mouth open most of the times. 9th and 10th nerve, the child was on NG feeds and there were no tongue fasciculations. The child had a frog-leg posture, increased frappability. The scarf sign was positive. The popliteal angle was more than 100 degrees with an adductor angle of around 180 degrees. On heel to ear, the legs were reaching up till the chin, and the child had right ankle equinus deformity. On active tone, the child had a reduced traction response, complete head lag on pull to sit. There were minimal anti-gravity movements at the elbow and only minimal movements in the plane of the bed in the lower limbs, and the DTRs were just elicitable. The primitive reflexes, palmar grasp was just present, whereas sucking, rooting were not elicitable, and moro reflex was depressed. So we can see that there is no traction at all. The child has a very weak cry. On pull to sit, there is complete head lag. And the scarf sign is positive. On the right, it is reaching till the midline, and on the left side, it is crossing the midline. The child has a very weak cry. So in database, we have a term baby boy born at 39 plus 3 weeks, born of emergency LSCS, low birth weight 2.4 kg, who did not cry immediately after birth, requiring resuscitation for 2 minutes with Apgar of 4 and 7, with neonatal encephalopathy secondary to hypoxic ischemic encephalopathy, who is floppy and weak, with lower limbs affected more than upper limb, with facial weakness, with bulbar weakness, with respiratory muscle weakness, with cryptorchidism, and right foot equinus. So our initial thought process was that we are dealing with a baby who is floppy weak with encephalopathy. So the cause can be combined peripheral plus central, as some antenatal scans showed dilated lateral ventricles and renal pilectasis, and the baby also had fetal growth restriction antenatally. So we thought of some chromosomal disorders, congenital muscular dystrophies, peroxisomal disorder, cerebral malformations. Second thought process was that we are dealing only with peripheral hypertonia, which is causing respiratory weakness, which is responsible for HIE. So the neuromuscular weakness is causing both weakness as well as encephalopathy. So localization and possibilities. Our first different localization was at the level of muscle, that we are dealing with congenital muscular dystrophy, as the antenatal scan showed bilateral dilated lateral ventricles. However, the odd features were that there was prominent facial weakness and no prominent contracture. There was only contracture at the right ankle. Second possibility was congenital myopathy in form of prominent facial weakness, but there was no ophthalmoparesis and no prominent contractures. Third possibility was congenital myotonic dystrophy. The child was very floppy, weak, had respiratory weakness, facial weakness, and feeding difficulties. Second localization was at the level of neuromuscular junction, thinking of congenital myasthenia or transitory myasthenia gravis. Third localization at anterior horn cell, considering SMA like type 1A or non-5q SMA like SMA-RD. However, the child had just elicitable DTRs and had no fasciculations. We also thought of spinal cord, injury at spinal cord, like at a cervical level, but there is no history of birth trauma, no bowel bladder involvement was present at initial presentation. So we sent the investigations. The CKNAG came out to be normal, 105. The ECG showed no fibrillations. The TFT was normal because the mother was on thyroxine supplement. So TFT was in, which was normal. Serum ACTH and cortisol was sent by the neonatology team, came out to be normal. The sepsis markers were also negative. The skeletal survey was performed and it seemed that the child had some hip dislocation. Then we went on to examine the mother. The mother examined on day 4 of life. She was admitted in the maternity ward. The mother did not give any history of weakness. She was having no difficulty in climbing upstairs, in raising up from the squatting position, writing, breaking rotis. But she was having hypothyroidism on thyroxine supplement since 4 years. She was having hirsutism. There was no cataract, no myotonia, and no obvious muscle wasting. On focused CNS examination, the mother had mild facial weakness in form of mild ptosis bilaterally, weak blowing, and elongated face. The bulk was normal in both upper limbs and lower limbs with normal tone in both upper and lower limbs, and the power was also normal. The reflexes were 2+ at the biceps, triceps, knee, ankle, and the plantars were flexors. There was no fatigability, no myotonia, and sensory examination was also normal. So in this video, we can see there is no grip myotonia. And in this video, we can see there is no eyelid myotonia. But she has some facial weakness. I'm easily able to open her eyes after asking her to shut it. She's not able to hold the air in her mouth. Also, there was no significant distal muscle weakness. So we went ahead and performed the EMG of the mother. The EMG of the mother showed myotonic discharges, 1+ fibrillations, and some repetitive discharges as well.
We can't hear the audio, Dr. Siddharth.
Hello.
Yes, ma'am.
We can't hear the audio from your presentation. When you share your screen, there is an option of no. Click on new share. Click on new share.
Just a minute.
Screen button below of your screen. Hello.
Just a minute, ma'am. Yes, ma'am.
Click on the green button. That is new share.
I'm not able to.
Okay, Dr. Siddharth, you can continue with the presentation. Later, you can present just the video.
Now you can share.
I'm sharing, ma'am.
Yeah. Share screen. Select your window and bottom. There is a 2 option in bottom. Share
Yes,
sound.
ma'am.
Yeah.
Share
Click
sound.
on share sound and then hit the share button.
Okay.
Yeah.
Should I
Yes.
start from the
Just the myotonia EMG video.
okay. Ma'am, was it audible?
Yes, yes.
So her final diagnosis was a term baby boy born at 39 plus 3 weeks of emergency LSCL, small for gestational age, floppy and weak, with lower limb affected more than upper limb, with facial weakness, with bulbar weakness, respiratory weakness, cryptorchidism, right foot equinus, with neonatal encephalopathy secondary to HI, with facial weakness and electrical myotonia present in the mother. So the etiology we thought was congenital myotonic dystrophy. We finally sent the genetics of both the mother as well as the baby, and they came out to be positive that the child had expanded CTG repeats, both the mother as well as the baby. So we must think of congenital myotonic dystrophy when the neonate presents with profound hypertonia, has especially facial weakness, poor feeding, respiratory weakness. There can be joint contractures, mainly in the lower limbs, especially at the ankles, causing club foot. In severely affected infants, there can be polyhydramnios, reduced fetal movements, severe respiratory weakness requiring mechanical ventilation. There can be associated feeding difficulties. Myotonia is generally not seen in the first or the second year of life. After the child survives the neonatal period, there is some improvement in the motor functions during the early childhood. And it is seen that the CTG repeats in congenital myotonia are usually more than 1,000. And the disease is almost always inherited from the mother. Also, there can be a history of prolonged labor can be present in the mother. Also, an interesting point is that there is no correlation between the severity of congenital myotonic dystrophy and the extent of complications in childhood or teenage years. So this is the diagnostic approach to congenital myotonic dystrophy in infants. Whenever we are dealing with infants or neonates who have profound hypertonia, respiratory failure, poor feeding, decreased facial movements, polyhydramnios or reduced fetal movements, or clubfoot deformity, we need to do a detailed family history and neurological examination of the mother as well. If the examination of the mother reveals myotonia, then we directly proceed with the genetic test. If any family member has symptoms of myotonic dystrophy, then we can again proceed with the genetic test. If there is a negative family history, but clinically we are suspecting that the child can be having myotonic dystrophy, then again we can proceed with a genetic test. Thank you.
Thank you, Dr. Siddharth, for the excellent presentation. I would like to invite Dr. Renu for comments and learning lessons from the case.
Thank you, Siddharth, for wonderful case presentation.
Thank you,
This case was very unique because when we saw first the baby in the nursery, labor room nursery, history of antenatal hydrocephalus was there possibly in this child, dilated ventricle. So initially our thought process was congenital muscular dystrophy. However, facial weakness and facial profile with clubfoot and hip dislocation was so prominent that it led us to think about a predominant element cause of floppy infant with HI as a secondary complication. And then on day 4 and day 5, when we evaluated the mother, we found that she has facial weakness, but there was no grip myotonia at that time. So then we went ahead with the EMG and we found myotonia in the muscles. So that's how the diagnosis was established in this patient. So another important point was that dilated ventricles in this baby. So children with congenital myotonic dystrophy do have CNS involvement. Near about 40% children can have a dilated ventricles, ventriculomegaly, and sometimes they can have thin cortex, as well as some of migration defects also. So this was a learning message for us that dilated ventricle could be a part of the spectrum of congenital myotonic dystrophy. So this was a take-home message. Thank you, Dr. Priyanka, and thank you, Dr. Siddharth, for wonderfully eliciting the videos and showing these videos here. Thank you so much.
Thank you.
Thank you, PGI team. I would request Dr. Lokesh Lingappa sir for any comments.
Hello. Yeah, I think that's a wonderful clinical case. I think comprehensive examination and taking the pain to examine the mother and getting the complete details of the history is very important. And one of the additional thing is while these children have respiratory failure, they do improve, as already mentioned. Some of them are stuck on ventilator for initial few weeks, but over a period of time, they tend to improve and then they come out of ventilator. Some may achieve ambulation as well. That's one aspect of this. It doesn't mean that once they're stuck on ventilator, poor outcomes discontinue. And what was the triple repeat length in the child and the mother? Any idea, Dr. Renu?
We got this repeat with the expanded CTG repeats. We did not get the exact numbers. We asked the lab also, but they just could not provide us the exact numbers. So definitely the mother possibly has a milder variant. Maybe she has a little bit premutation or mild weakness, but the baby definitely had a significantly expanded segment.
Yeah, and even without HIE, these children can have neonatal encephalopathy as part of the myotonic dystrophy as such. So if you don't have MRI changes of HIE, still child is encephalopathic, that can be attributed to the myotonic dystrophy as such. So that is also possible. Thank you.
We have a few questions in Q&A section. So what was the size of ventricles in fetal MRI? Dr. Siddharth?
Ma'am, fetal MRI was not done. Fetal ultrasound was done. I'll just let you know, ma'am, 1 minute.
And there is a question on genetics testing, whether it is free at CSIR Hyderabad.
No, ma'am,
It is a paid investigation.
It is.
Yes.
So there is another question. Dilated ventricles and renal pylectasis are soft markers for aneuploidy. How relevant with hydrocephalus and myotonia?
Possibly he had mild ventriculomegaly because there was no cortical malformation as such. It was not reported as hydrocephalus. There is no posterior fossa malformation which are pointers toward a CMD. So there may be a mild ventriculomegaly. Till now we have not imaged the baby at present, and we may image him later on. Initially we thought of an aneuploidy or chromosomal disorder as a differential diagnosis. However, once we have examined the mother, all these things becomes very clear that she has a kind of a mild myotonic dystrophy, and the baby had a severe presentation with possibly HI, or it may be part of the myotonic dystrophy per se.
And there is another question. Any experience with HIV presenting as neonatal encephalopathy?
No, I have not seen a HIV baby. Maybe have seen more with complications in terms of infection and all, but as per se HIV, we have seen older children who present with developmental delay, microcephaly, as well as epilepsy. So that spectrum we have seen, but a neonatal encephalopathy, I have not come across.
Thank you, Dr. Renu and Dr. Siddharth. We move on to the next and the last case, which will be presented by Dr. Shweta from Sri Ramachandra Institute of Higher Education, Chennai. Her mentor is Dr. Ranjit, who is Associate Professor and Consultant in Pediatric Neurology and Epileptology at the same institute. Over to Dr. Shweta.
Yes, ma'am.
Screen sharing. Yeah, we can see your slides.
Put it on slideshow mode, ma'am.
Is it okay now, ma'am?
Yeah, it's in editing mode. The PowerPoint is in editing mode. Can you put it on slideshow mode?
Yes, ma'am. I've put the slideshow.
At top menu bar, there is an option of slideshow. Click on that. In menu bar, yeah.
Yes, it's fine. Please go ahead, Dr.
Yes.
Shweta.
Yes, ma'am. Good evening. I myself am Dr. Shweta Amuthan, a pediatric resident from Sriha, and my guide is Dr. Ranjit Kumar, who's an associate professor and consultant of pediatric neurologist and epitologist. Here I'm presenting a case of hypertonic infant, a common diagnosis but often missed. So we have a baby, a 7-month-old female child from Chennai, brought by anxious parents who are in their 40s. The main complaints were delay in attainment of milestones and not gaining weight, that is failure to thrive. A 7-month-old girl, baby born out of non-consanguineous marriage, presented with complaints of delay in attainment of milestones. Currently, the child has attained the neck control, rolls over from supine to prone position, sits with support, social smile present, recognizes the mother, bidextrous reach for object is seen, and cooing is seen. Complaints of poor weight gain. Birth weight was 2.75 kgs, and currently the weight of the child is 5.2 kgs. So birth history, antenatal, the mother was booked and immunized, iron and folic acids were taken, and the mother was a hyperthyroid. Natal history, the child was late preterm, 36 weeks plus 6 days. It was born by LSCS, and the reason was polyhydramnios and cried at birth. Postnatal, the child did not take DBF well. Sucking was noted to be poor, and hence Palari feeds were initiated. Currently, the child is on complementary feeds. Immunization was taken as per national immunization schedule. Anthropometry revealed the weight of the child was less than -3 Z-score. General examination, subtle dysmorphism was noted, which was non-specific. Parent denied the consent for taking pictures, hence we are not sharing any of them. Anterior fontanel was at level 1.5 cross 1.5. Vitals were stable. No cyanosis, clubbing, icterus, lymphadenopathy, or pedal edema was noted. CNS examination revealed hypotonia, which was appendicular and axial were equal. And on pull to sit, mild head lag was present. Power was at least more than 3 in all 4 limbs, and anti-gravity movements were present. Deep tendon reflexes were just elicitable, and plantar was flexor. Other systemic examination were normal.
Hi,
So
Dr.
summary.
Sweta, go ahead. Yeah,
Yes.
keep it.
Yes. 7-month-old late preterm girl baby born out of non-consanguineous marriage, presented with delayed attainment of milestones, predominantly motor, failure to thrive, subtle dysmorphic features, which is non-specific with central hypotonia. We proceeded with investigation. Serum CPK total was normal. MRI brain and spine was normal. Thyroid profile for the child was also normal.
Yeah, thanks, Dr. Sweta. Hold on. Yeah. Dr. Priyanka, would you like to encourage some discussion at this point? Any possibilities and what should be the next step?
Yes, so we can have the clinical possibilities from the audience, from the attendees. They can type in Q&A section.
What do you think are the possible clinical possibilities given this clinical scenario, and what should be the ideal next step?
Please type in Q&A section. Dr. Ranjit, would you like to repeat the syndromic diagnosis?
Yeah, so just one small correction from Dr. Sweta's presentation. So it can do supine to prone, but does not do prone to supine and does not sit with support. So that's not. So here is a 7-month-old baby who is presenting with developmental delay, predominantly motor, and also has poor weight gain. And on examination, we find subtle dysmorphism and central hypotonia-like picture.
So we have few answers in the chat box. One is infantile Pompe's disease. Then we have Prader-Willi. Then they are asking about examination of mother, CPK NAC, RTA.
Yeah, so brief examination of mother, it was normal. There was no evidence of any neuromuscular illness in mother. CPK was normal. Electrolytes and blood gas were normal, so we didn't think of RTA. So what do you think should be the next investigation in this scenario? Just to add, MRI brain is also normal. anyone would like to put in the chat box? ECG, echo, thyroid.
Yes.
Yeah, so thyroid profile is also normal. Okay. So Dr. Renu asked about feeding issues. Yeah, so moms, one of the initial complaint or initial issue which the parents brought up was sucking difficulty, and also has some feeding issues and not gaining adequate weight. So I won't make you wait for a long time. So before that, I will go to the Forster slide. Dr. Shweta, do you want to show that slide? So for trainees and residents who are here, this is one very important bedside examination which we do in any hypotonic infant to see is the baby having a central kind of hypotonia or peripheral hypotonia. So we lift the baby by the shoulders with the face facing away and tickle the foot of the baby and see what is happening. So you can clearly see if the level of if the lower limbs are able to lift above the level of pelvis, then you are dealing with central hypotonia. If it is hanging low, then it is peripheral hypotonia. In this baby, the baby was at least able to bring up to the level of pelvis. So we were having a central hypotonia picture. But all pointers are pointing towards a central hypotonia and a possible kind of a syndromic etiology presenting with a failure to thrive. And we did genetic testing. We went for a whole exome sequencing. Can you show the slide? Can you show the result? So this is what we got. A contiguous deletion involving 5 kilobases, like 4,700 megabases to be exact, of chromosome 15, which spans multiple genes, including the Prader-Willi gene. So, so they recommended further testing to confirm the diagnosis. Is it a Prader-Willi kind of a presentation or something else? So what should be the ideal next step given this deletion to confirm is it Prader-Willi syndrome? Would you like to type in the chat box? Excellent. So methylation specific MLPA will be the ideal test in this scenario to confirm. So we did that test and it showed absence of maternally mediated methylation, thereby confirming the diagnosis of Prader-Willi syndrome. So the take-home message from this slide, from this presentation is, whenever you have a child who has infantile hypotonia, delayed milestones, particularly with a history of poor suck, even though without classical dysmorphic features suggestive of Prader-Willi, like you may not get that almond eyes, tapering fingers in this age group, and you may not get the obesity or hypophagia in this age group. Actually, it starts beyond 2 years of age. So in fact, in this case, when we send the genetic testing, we didn't think of Prader-Willi, to be frank. So that's one of the important message which we should learn in infantile hypotonia syndromes. Thank you very much for the opportunity. Yeah.
Thank you, Sri Ramachandra team. So we can have some comments from the experts. Dr. Lokesh, sir.
Hello. Yeah, I think very important. Epidemiologically, the commonest reasons for hypofloppy infant floppy neonate would be one of them would be the Prader-Willi syndrome. In fact, in UK, the initial protocol for floppy infant were to test SMA gene and the Prader-Willi syndrome long back. I think now things would have changed a little, but epidemiologically, those are the two common things to present in the newborn period as floppy newborn. So I think those are the things once you differentiate between central versus peripheral hypotonia, if you're looking at central, and that will be the one of the commonest pathology if you have ruled out all the acquired.
Thank you, sir. Even the other sister disorder of Prader-Willi, Angelman, can also present with central hypotonia. So there is a question in Q&A section. Why was whole exome done instead of microarray in the first instance? This is a question by Dr. Indrashit. Dr. Ranjit?
Yeah, so that's a very good question. So we usually divide developmental delays into syndromic and non-syndromic causes. So in this situation, frankly speaking, we didn't think of a specific syndrome when the child presented, although I'm not showing a picture here. So it was more like a non-syndromic developmental delay kind of a presentation, wherein the yield of whole exome sequencing is more. And also in the current scenario, even whole exome is able to pick up copy number variations. Actually, the report clearly mentions presence of a copy number variation and a large contiguous deletions. So nowadays, I think we can go ahead with the whole exome, which has more yield than microarray in this kind of a non-syndromic or kind of a broader presentation. Open to any further comments on this specific question.
I think Ranjit, very well done with your team. I'm just requesting that now we request Rachna, Dr. Rachna Dubey very kindly agreed to present the approach. So we just give her the time now, please. Yeah, please, Dr. Rachna.
Thank you, ma'am. Actually, we already heard, I guess, practically everything which comes in under this domain, and they're beautifully presented by all of them. Also, the approach has been practically taken up with each one, like, each presentation. And what I'm going to do is really, I should say, a sum up type. I should say ABC or something very, very basic to this audience. Am I sharing my screen? Everyone is able to see that?
Yes, ma'am. Your screen visible.
So, ma'am was saying, like, I would be talking much on genetics and all, but this is more on a clinical approach, I should say. I guess individually, like, everyone did present like approach, and the discussions on investigations we did have quite a bit. So let's see what is the ABC of floppy infant, I should say. So what is this phenomena when we say floppy? So actually in clinical sense, when we mean floppy, possibly, we are looking at these three things, either hypotonia, which is decreased muscle tone, or decrease in muscle power, or ligamentous laxity and increased joint motility or joint laxity. And in fact, when we are evaluating a patient clinically, they can look little mixed up. Though in stricter sense, when we want to use floppy, we want to mean hypotonia. So the term floppy actually is more relevant to hypotonia, but clinically when we see or examine a patient, it's the weakness, ligamentous laxity, joint motility that also comes in our way for examining and also labeling a child. So what is the localization of hypotonia or the tone? We can see here, like, it looks like practically everything. It's very, very ubiquitous. So we can see here that CNS and and rightly I have kept most up, because still they can be one of the most common or the commonest, localization pointers for the hypotonia. Motor unit, of course, like, when we want to say we are on the neuromuscle side, we are always eyeing onto this part, which is anterior horn cell, nerve, NMJ, and muscle. And of course, they are important for further diagnosis, treatment, prognostication, and in fact, beginning of the algorithm itself. So this is always on our mind when we see a floppy infant or a neonate. Anatomic localization, this is something which is very, very basic and does help us every time whenever we see a child. So we can see here that the first column, in fact, first is variable, the second is central injury, which we call as central hypotonia as central causes, and rest four which are followed, like anterior horn cell, peripheral nerve, NMJ, and muscle are more of like, peripheral. So central versus peripheral, and peripheral is more of motor unit. And whatever is in red is practically like, what I want to kind of emphasize. So we can see here when it comes to strength, we want to say central versus peripheral. Central causes can have nearly normal strength. Deep tendon reflexes can be brisk, and that will give us a very quick clue and a pointer. If the reflexes are absent, we are immediately jumping on to anterior horn cell or peripheral nerve. Similar is with Babinski's, because if it is positive, that means definitely we are on central cause for hypotonia. Primitive reflexes, if they are present, we are on central cause. Fasciculations, if we see very clearly, we are on anterior horn cell. So something which is very quickly narrowing down our differential diagnosis. Similarly, muscle mass, typically in central NMJ, it will be normal, or sometimes a diffuse atrophy in central injury. And otherwise in anterior horn cell, commonly proximal atrophy, though we always can have cases and causes where we can have it other way around as well. Peripheral nerve invariably will have distal atrophy, and muscle, of course, as we know, we can have proximal distal both. Coming to etiological spectrum, as I said, it could be practically anything what we see here on the list. So, of course, this is not complete, but yes, trying to emphasize again on central hypotonia, cerebral, cerebellar, syndromic, chromosomal, metabolic, including storage, neurometabolic, etc. More commonly, mitochondrial, IEMs, and organic acidemia, everything practically can present as hypotonia. Nutritional, which could be maternal or which could be infant and neonate itself. Not to forget B12, vitamin D, especially in the areas where we see them more commonly. Endocrine disorders, including hypothyroidism, hypopituitarism, etc. And element, of course, this we have emphasized in all 4 cases which we presented here. Drugs, not to forget the maternal drugs. In fact, whenever we get a call from NICU related to hypotonia, I guess this is one thing which should be thoroughly interrogated. Maternal examination, maternal drugs, maternal medications, especially magnesium, benzodiazepines, antipsychotics, anesthetic agents, etc., have to be probed in detail, because just waiting for that drug to wash out can really rule out a lot of lengthy workup, which otherwise we end up into. Mixed and other system, like, it is not uncommon to see somebody having a serious cardiovascular illness or other system disorder and presenting with hypotonia, poor muscle tone because of poor muscle bulk. So practically here we have to have a pediatrician's perspective when we see a patient with floppiness or hypertonia. When it comes to clinical approach, we have already seen very, very elaborate presentations. So again, I'm emphasizing here that whatever we are doing in terms of general examination and specific neuromuscle and CNS examination, our whole focus is trying to catch, is it central versus peripheral or weak versus strong? And trying to see something which is giving us a direct narrow down of the diagnosis, like looking at dysmorphism, looking at limbs, skin for laxity, cutis laxa, collagenopathy related markers, abnormal fat distribution, inverted lipple for CDG disorders, gonads, hernial sites, organomegaly for storage disorders. So there are some very few snippets, I should say, which we can see here, which is more on general examination. So in fact, general examination is very important part for anybody who's presenting with floppiness. So a thorough check on dysmorphic features if any patient who's having. Also the facial examination for tented upper lip, high arch palate. Not to forget joint laxity, multiple contractures, fixed posture, eager look, which you can see here. Eager look generally is telling us that CNS wise or understanding wise, this infant is pretty intact. So we can see here, these patients, the pictures which you are seeing here, which have contractures, very, very normal looking child otherwise, and arachnodactyly. So this was Beale's congenital contractural arachnodactyly. And just looking a good general thorough examination would tell you that possibly you just need to do a further investigation only on this site. Pit frog appearance, which again is something which is very, very characteristic, immediately will tell you about the floppiness, central and axial and peripheral. Again, there are just few examples. for syndromic and children, and we can see a few of the pictures over here. One is this, all four which you're seeing on the top is from Zubair syndrome, showing hypotonia, global developmental delay, ataxia, nystagmus, also had apnea in the neonatal period, and we can see a classical modal tooth sign here on the MRI. Not to forget Mebius syndrome-like patients where they can have almost facial diplegia-like picture presenting like myopathic faces, again having CTEV-like picture, and we can see here ophthalmoparesis. So this is Mebius presenting like initially as a myopathic faces. Coming to, again, CNS examination, not to be forgotten, as higher function, sensorium, encephalopathy, reflexes, wakefulness, cranial nerves, which are predominantly motor, should be specially looked at. Sensory system, autonomic system, and any involuntary movements if they are there, and even cerebellar signs. So obviously for cerebellar signs, we know that most of the central hypotonia patients could be having enough strength to see everything. So central CNS examination, higher function will again delineate the central versus peripheral causes of floppiness. Motor system, whenever we examine, especially a neonate, gestation, alertness, medication, systemic illness have to be looked into carefully. And clinical evaluation of tone is very important, and often at the level of resident, we are always confused what to call it, active versus passive. So it's always a good idea to put it down while you are doing it. So active tone, of course, whenever you are asked, you are expecting the baby or the infant to do something. So like in pull to sit, traction response, scarf sign, shoulder axillary suspension, ventral suspension, all this will come in active tone examination. And can we measure it? Yes, adductor, popliteal, ankle dorsiflexion, all this will be a good guide. But in absolute measure, yes, it's not possible for all ages, but yes, in infancy and first couple of years, of course, the angles do help us. So adductor, popliteal, scarf sign, ankle dorsiflexion, and we should always have something to go by. So it's good to keep these handy to keep a check on. Just trying to, again, emphasize on passive tone here. So whenever we are looking at passive tone, it's posture, heel to ear, popliteal angle, adductor angle, ankle dorsiflexion, and scarf sign. And active is pull to sit, axillary suspension, and ventral suspension. So we can see here on axillary suspension, it's always a slip through kind of feeling, which we can see. And this is a pull to sit phenomena. Ideally, we should be holding this baby from shoulder because we can see it's completely axial and appendicular hypotonia, which you can see here. Some special sign which should not be missed as an anterior horn cell localization, one being fasciculation, which can be seen in anterior horn cell disorder, including Pompe, sometimes neuropathy, and of course, neuronopathy, they are the markers. Polymini myoclonus, again, anterior horn cell localization, but can also be seen at times in CMT and also in recovering GBS at times. Coming to an approach, how do we follow? So after a history and clinical examination, there is one arm which is towards hypotonia, altered sensorium, seizures, feeding difficulty, apnea, posturing, and DTRs which are preserved or brisk. So possibly everything presenting towards the central causes. Neuroimaging, sepsis workup, CSF, IEM screen, looking for perinatal asphyxia, IEM, and CNS malformation. On the other side, we have hypotonia, weakness, alert look, contractures, fasciculations, depressed DTRs. Maternal examination, if we have seen a very good case presented. Normal, then it's on the next slide. When it is abnormal, then of course to check for drugs, myotonia, myasthenia, and to rule out congenital myotonic dystrophy and transient myasthenia. Dysmorphic malformations can come from both the sides. And we have to check karyotype, FISH, and chromosomal microarray for those cases. Now coming to where maternal examination is normal, then we go for CPK, which could be high or normal. If it is high, then congenital muscular dystrophy, congenital myotonic dystrophy, like the first case, which we had seen. And of course, muscle biopsy, clinical exome, whole exome, NGS, repeats specifically when we are suspecting, because just doing WES may not give us a solution in cases like congenital myotonic dystrophy. When CPK is normal, SMN gene deletion, because this is something which could be really common, and initially itself we can have a diagnosis which is nil. And if SMN deletion is absent, then of course the role of electrophysiology comes, which we can see is pretty limited, and will give us a clue on myopathy, neuropathy, and NMJ disorder. And of course, myopathy, then further NGS followed by muscle biopsy, or either way. Neuropathy, we have normal nerve conduction. Then again, we can have non-5q SMA. If we have NCV, which is suggesting us involvement of peripheral nerve, then CMT and peripheral neuropathy. And NMJ, of course, congenital myasthenia, NGS, and RNST giving us a clue on that. So this is kind of a broad, very broad perspective. Now, what is the yield of whatever we do to diagnose the floppy ones? This is a very old write-up, I should say, from 2004. And if we have to rewrite it, and of course, this genetic testing part will improve very greatly. So just to emphasize again, 50% yield just with history and physical examination. So just a clinical examination giving us clue on 50% cases, and not uncommon, because dysmorphic patients are pretty common when we see floppy infant or neonate. Imaging, CNS imaging, diagnosing central causes, 13%. Neuromuscular testing in all together, everything giving only 6%. So that means if we have imaging and clinical acumen, then obviously 60% cases, we can have some clue on diagnosis. Just snippets on couple of cases of almost extension of what we heard from everyone who presented cases today. So this is 4-year-old, generalized floppiness, global developmental delay, feeding difficulties since beginning, occasional seizures. So we almost have a feeling of something mixed happening here. Generalized hypotonia, flabby muscles, weakness, which is facial, appendicular, axial muscles, contractures, hyperreflexia, UMN plus LMN, and everything is pretty visible over here. CPK 852, we have an imaging over here, which is very characteristic, pachygyric cortex, and we can see cerebellar cyst very nicely over here. So T1, T2 demonstrating white matter changes, pachygyria, and cerebellar cyst. So this patient had Fukuyama CMD, and a good example for somebody who present like a mixed picture. Coming to just case 2, this is a 6-month-old. I have been showing this baby on aspect frog and pull to sit throughout, right? So 6-month-old, GDD, floppy, seizures, failure to thrive, and weak on examination. CPK was normal, and this is the MRI brain over here. So I'm just trying to emphasize over here that another important central cause for showing such a floppy baby. So SURF1 mutations, mitochondrial disorders, they all can present exactly like a floppy neuromuscular case. And at times they can have central cognition and learning pretty intact till late. So should be kept in mind very early on itself. Third one, again, I have seen very commonly these patients presenting as floppy. 11-month-old, floppy, presenting just as a delay. Neonatal history was little significant, was preterm, admitted to an ICU, and had a CNS event. Head size we can see here is on a higher side. So clearly a hypotonic, wobbly child taking all the support of the mother when made to sit. Fine motor skills, cognition, etc. looks absolutely fine. And when we look at it, the MRI is showing clearly arrested hydrocephalus like picture with significant white matter involvement. So just trying to emphasize again here that so much happening in the MRI, but if you look at the babies, completely floppy, BTRs were present to 2+ side, but there is no trace of spasticity or so to say tightness or anything. So hydrocephalus patients do present as hypotonia or floppiness. So to conclude, central causes of hypotonia account for roughly 60 to 80% of neonatal and early infant cases. History, clinical examination, neuroimaging, and focused genetic testing can diagnose up to 60% of hypotonic infants. Judicious electrophysiology in patients with normal CK, neuropathy, myopathy versus anterior cell, NMJ, this is where it can help us. Genetic test, which is like, should be tailored for individually for each patient. And if we are not in hurry, then it can be stepwise also. Genetic evaluation, antenatal counseling is essential practically in all cases. So thank you so much. This was just a sum up, I should say. I should stop sharing my screen. Yeah. Thank you.
Thank you, ma'am, for wonderfully summarizing an algorithmic approach to floppy infant. And the cases of central hypotonia were excellent. And thank you for the wonderful presentation. So, we have one question, ma'am. Why Down syndrome has hypotonia? Any explanation?
Yeah, so actually, all like, I should say like recently, like, I have come across a lot on epigenetics. So Down syndrome and even Prader-Willi and Angelman all are considered as epigenetic and genomic imprinting. So in fact, when it comes to trisomy 21, everything, whatever is happening is more like epigenetics. So that's the reason we see very, very varied presentation on trisomy 21. So one patient can have presentation. So practically, if we go on trisomy 21, then it is majorly epigenetics, which is causing all the manifestations what we are seeing. And including hypotonia, yes.
Thank you, ma'am. There is another question. Hydrocephalus usually presents with increased tone. How will there be hypotonia?
Yeah, so this is what I was trying to explain here, that invariably with hydrocephalus, we will expect that there will be increased tone. But yes, involvement of white matter, involvement of fourth ventricle, and there are cases and reports where these patients will present with central hypotonia. So this was the unusual thing. That's the reason I tried to include it over here. And not uncommon at all. Not uncommon at all.
And it can sometimes present with ataxic features also. No?
Yes, yes. Especially if you have a fourth ventricle, which is trapped, which was not there in this case. They will classically be ataxic as well. And they can come up later as well. And treating that part can handle their ataxia. But yes, this patient did not have anything like fourth ventricle trap.
Thank you, ma'am. So now I invite expert Dr. Lokesh sir for any comments, and then panelists.
Dr. Rashmi is there. Dr. Rashmi Kumar ma'am would like to say something. Any comments? Dr. Rashmi?
Yes.
Anji,
yeah, it's a very nicely done presentation. I mean, the whole session was very nicely done, covering diverse cases and, through the spectrum of this problem of floppy infant. So, of course, there are other causes which you've covered, very important ones very nicely. And last of all, we had Rachna summing up everything. So I think that was also very beautiful. So let's keep it up. Very good.
Thank you, ma'am. Gurpreet, co-convener. No?
Nothing much to add. It's again a very nice presentation. Thank you all the presenters, and I think that's it.
Thank you. And anybody else from the SIG wants to say anything? Dr. Rajesh, Dr. Anita.
No, it is a very nice presentation, a lot of good cases, and both the clinical approach as well as the value of investigations has been nicely done. I think it's very good learning experience. Thank you for all the presenters.
Thank
A
you.
very nice
Anita?
session. Very nice.
Thank you. I think before I hand over to Mahesh, I would personally thank all the presenters and thank you, Rachna, for agreeing at the very short notice. And I think it all went out well. I think everybody should keep that next many months to come, Wednesdays 8 to 9:30 p.m. blocked. And anyway, if you miss anything, we will be putting all of them on the website and in the YouTube channel as well. Over to you, Mahesh.
I would like to thank all the presenters and their moderators for the wonderful 4 cases we had today, covering the entire spectrum of floppy infant. And next week, Wednesday, again, we'll have another session, the details of which will be put up in both WhatsApp group and will be mailed to all of you. And I expect all of you to join us next week at 8 p.m. Thank you.
Thank you. Bye. Good night.
Good night.
Thank you, everybody. Good night. Thank you, Dr. Priyanka.
Thank you, ma'am. Thank you, everyone. Good night, everyone.
Wonderful session. Thank you so much.
Thank you.